This recording will go over diverticular disease as well as celiac disease. Diverticula are pouch-like herniations of the mucosa through the muscular wall of any part of the gut, but most commonly the colon. Diverticulosis is the presence of many abnormal pouch-like herniations in the wall of the intestine. You see, so just examples of just that outpouching. Acute diverticulitis, right? So you know that what itis means is the inflammation or infection of diverticula. Outpouching with infection and inflammation. Diverticula can occur in any part of the small or large intestine, but usually occur in the sigmoid colon. The muscle of the colon hypertrophies, thickens, and becomes rigid, and herniation of the mucosa and submucosa through the colon wall is seen. Diverticula seem to occur at points of weakness in the intestinal wall, often at areas where blood vessels interrupt the muscular layer. Diverticula without inflammation cause few problems. However, if undigested food or bacteria become trapped in the diverticulum, blood supply to that area is reduced. Bacteria invade the diverticulum, resulting in diverticulitis, which then can perforate and develop a local abscess. A perforated diverticulum can progress to intra-abdominal perforation with peritonitis. Diets low in fiber that cause less bulky stool and constipation have been implicated in the formation of diverticuli. Retained undigested food in diverticuli is suggested to be one cause of diverticulitis. The retained food reduces blood flow to the area and makes bacterial invasion of the sac easier. In terms of assessment, the patient with diverticulosis usually has no symptoms. Unless pain or bleeding develops, the condition may go undiagnosed. Diverticuli are most often diagnosed during routine colonoscopies. Ask the patient about intermittent pain in the left lower quadrant and a history of constipation. If diverticulitis is suspected, ask about a history of low-grade fever, nausea, and abdominal pain. Inquire about recent bowel elimination patterns because constipation may develop as a result of intestinal inflammation. Also, ask about any bleeding from the rectum. The patient with diverticulitis may have abdominal pain, most often localized to the left lower quadrant. It is intermittent at first, but becomes progressively steady. Occasionally, pain may be just above the pubic bone or may occur on one side. Abdominal pain is generalized if peritonitis has occurred. Nausea and vomiting are common. The patient's temperature is elevated, ranging from a low-grade fever to 101 degrees Fahrenheit. Chills may be present. Often, an increased heart rate, tachycardia, occurs with the fever. On examination of the abdomen, observe for distension. The patient may report tenderness over the involved area. Localized muscle spasm, guarded movement, and rebound tenderness may be present with peritoneal irritation. If generalized peritonitis is present, profound guarding occurs, rebound tenderness is more widespread, and sepsis, hypotension, or hypovolemic shock can occur. Blood pressure checks may show orthostatic changes. If bleeding is massive, the patient may have hypovolemia and hypotension that result in shock. The first sign of peritonitis in older adults may be a sudden change in mental status, such as acute confusion. For those who have dementia, the confusion worsens. Fevers and chills may not be present because of normal physiologic changes associated with aging. The patient with diverticulitis has an elevated white blood cell count. Decreased hematocrit and hemoglobin values are common if chronic or severe bleeding occurs. Stool tests for occult blood, if requested, are sometimes positive. Abdominal X-rays may be done to evaluate for free air and fluid indicating perforation. A CT scan may be performed to diagnose an abscess or thickening of the bowel related to diverticulitis. Abdominal ultrasound may also reveal bowel thickening or an abscess. The healthcare provider may recommend a colonoscopy 4 to 8 weeks after the acute phase of the illness to rule out a tumor in the large intestine, particularly if the patient has rectal bleeding. In regards to interventions, patients are managed on an ambulatory care basis if the symptoms are mild. Monitor the patient for any prolonged or increased fever, abdominal pain, or blood in the stool. The patient with moderate to severe diverticulitis may need hospitalization, especially if he or she is older or has complications. Manifestations suggesting the need for admission are a temperature higher than 101 degrees Fahrenheit, persistent and severe abdominal pain for more than 3 days, and/or lower GI bleeding. A combination of drug and nutrition therapy with rest is used to decrease the inflammation associated with diverticular disease. Broad-spectrum antimicrobial drugs, such as metronidazole in conjunction with trimethoprim sulfamethoxazole or Cipro, are often prescribed. A mild analgesic may be given for pain. Please review the chart in your textbook that lists nursing interventions for the older adult. The patient with more severe pain may be admitted to the hospital for IV fluids to correct dehydration and IV drug therapy. For patients with moderate to severe diverticulitis, an opioid analgesic may alleviate pain. Laxatives and enemas are avoided because they increase intestinal motility. Assess the patient on an ongoing basis for manifestations of impaired fluid and electrolyte balance. Teach the patient to rest during the acute phase of illness. Remind him or her to refrain from lifting, straining, coughing, or bending to avoid an increase in intra-abdominal pressure, which can result in perforation of the diverticulum. Nutrition therapy should be restricted to low fiber or clear liquids based on symptoms. The patients with more severe symptom is NPO, and an NG tube may be inserted if nausea, vomiting, or abdominal distension is severe. Diverticulitis can result in rupture of diverticulum with peritonitis, pelvic abscess, bowel obstruction, fistula, persistent fever or pain, or uncontrolled bleeding. The surgeon performs emergency surgery if peritonitis, bowel obstruction, or pelvic abscess is present. Patients with diverticular disease need education regarding a high-fiber diet. Encourage the patient with diverticulosis to eat a diet high in cellulose and hemocellulose types of fiber. These substances can be found in wheat bran, whole grain breads, and cereals. Teach patients to eat at least 25 to 35 grams of fiber per day. Fresh fruit and vegetables with high fiber content are added to provide bulk to stool. The patient can also add a bulk-forming laxative such as psyllium hydrophilic mucoid, and that can be taken to increase fecal size and consistency. Teach the patient to drink plenty of fluids to help prevent bloating that may occur with a high-fiber diet. Alcohol should be avoided because it irritates the bowel. Foods containing seeds or indigestible material that may block the diverticulum, such as nuts, corn, popcorn, cucumbers, tomatoes, figs, and strawberries, may need to be eliminated. The patient should be instructed to avoid all fiber when symptoms of a diverticulitis are present because high fiber foods can be irritating. As inflammation resolves, fiber can be gradually added until progression to a high fiber diet is established. Celiac disease is a multi-system autoimmune disease with an estimated incidence as high as 1 in 250 of the world's population. Celiac disease is a chronic inflammation of the small intestinal mucosa that can cause bowel wall atrophy, malabsorption, and diarrhea. Patients with celiac disease have varying signs and symptoms with cycles of remission and exacerbation, usually related to how well they monitor their diet. Classic symptoms include anorexia, diarrhea and/or constipation, steatorrhea, abdominal pain, abdominal bloating and distension, and weight loss. Some patients have no symptoms. Still others have atypical symptoms. Be familiar with the classic symptoms for celiac disease that are listed in the chart of key features in your book. Dietary management is the only available treatment for achieving disease remission. In most cases, a gluten-free diet results in healing the intestinal mucosa after about 2 years. Gluten is the primary substance in wheat and wheat-based products. Teach patients to carefully check for hidden sources of gluten that are in foods, food additives, drugs, and cosmetics. A registered dietitian should be included in the patient's long-term planning and overall treatment.